Today's session is on practice, and I've been privileged to be involved with practice with the Academy for several years and have chaired the practice committee, but the change has been enormous. So let's go back in the time machine that we've lived in, and I know Kathy will remember some of this, that CMS and the payers were passive players for many of the years. You submitted your bill, they paid it. So that has changed and is continuing to evolve. So CMS was one of the great social welfare systems that emerged with Medicare. And again, they were passive receivers of what we sent to them as providers and physicians. Well, now they are very aggressive, engaged purchasers. 15 to 18 years ago, there was a realization in at least North America that the diversity of care, not just in populations, but in cost and outcomes, was starting to be realized. Part of that was, why would a group of patients in Texas have much better outcomes and much better detection of colon cancer by an endoscopy at half the cost of what was done in New Jersey? Same humans, a little different population, but if they matched it, those were the diversities. So that also was of interest, but what really drove this? Well, we're out of money. And the projection, certainly of CMS, was it would run out of money in 2017 unless there were patches which have already occurred. So this all led to really scrutinizing how we look at both patients, diversity of care and outcomes, and then developing quality into it. Where are we at now after this evolution? Well, Institute of Healthcare Improvement out of Boston came out over 10 years ago, well, really 15 years ago, what's called the Triple Aim. Does anybody know the Triple Aim? Kathy, you, oh, okay. The Triple Aim came out of IHI, Don Berwick's group, who was one of the early almost zealots of looking at linking quality and cost and care. And the Triple Aim is reducing cost of health care, ensuring quality and satisfaction through patient engagement, and then finally, not looking at treating a person, but in addition, looking at treating a population, and that we're responsible for those three things. And it really was, it's simple conceptually, but it was never looked at that way. And now it is, of course. So what has that led to now down through the ages? Well, with the explosion of accomplishments, of technologies, of pharmaceuticals, of physicians, of care, we're looking at changing the paradigm. And well, I call this the future is now. While we're looking at it, it has occurred. So for those of you who feel this is all a future experiment, it's not an experiment. And let me go through why. We're looking at volume to value, and I break it up into 4 areas. Volume to value. We're not looking anymore at really seeing numbers of patients, although those of you seeing patients still have to, but that is going to change a bit. Information systems, meaningful use, where CMS and HHS paid and gave a reward to those entities, either individual physicians or healthcare systems, who develop electronic health records and different levels of availability of what you can do with your health record. New payer expectations. Obviously, payers have followed CMS. They're now purchasers, and they're going to look for a few things. First and foremost, low cost. Second, access for patients. Third, what are you doing either as an individual physician or as a group to ensure that there's better quality for the population you serve? The Triple Aim. Actually, there's a quadruple aim. At the end, we'll go into that. And then finally, new patient expectations. Patients are now the choosers of their health care. They choose how, when, where, to many times. There are obviously some restrictions because of the payers. So it's this dance between payers and patients. And so the choice historically was, my family, my doctor was always Dr. Smith. I'm going to do whatever Dr. Smith says. It's not the case. So what are we doing now? Well, the future is now. 2014, 40% of physician and principally hospital payments had some area of quality linked to their reimbursements, either through CMS or from individual insurers that had contracted with that hospital. So that really began several years ago. Number two, January, link of 30% of all Medicare payments to quality and value by the end of 2016, and 50% of all payments switching from volume. You saw 10 patients, we're paying you for 10 patients, to you're seeing 10 patients, but by metrics that we're going to analyze and you're going to submit, we're going to pay you based on how that quality takes place. So again, it goes to that triple aim. They're paying for you treating a population. We're also paying you for treating an individual, linked to quality, and what's part of quality is timely access. So there we have again, leading all into that triple aim, and now it's being actually systematized. Hi, Dr. Goodman. How are you? Thank you. Excellent. Oh, well, you're kind. I don't think there's anything I can teach you, but thank you for being here. And then finally, in March of this year, a couple weeks ago, HHS announced that they're way ahead of schedule. APM. Okay, an alternative payment method. If you want to learn so much about how we're now going to be paid, go over to the macro site, M-A-C-R-O. I'll get to that, but that is just right over there, 2 storyboards over, and talk to the staff there, and they'll be able to fully educate you on how this has evolved. So at St. Luke's system where I work, not only have we been through 1 round of information technology and vendors, we're now going to our 2nd round, which for a system that's about $1.6 billion in revenues, mid-size in today's market, we've already spent in excess of $150 million on healthcare technology. That's the part that links it together. So, okay, who's flying home? This, to me, is patient decision making. When you're going to go on vacation this summer, what are you going to choose your airline by? Price. And what might you choose secondly? Whether they have enough flights to that area. Access. So patients are now doing this. Payers are definitely doing this and changing it rapidly. So if you book with a returnable deposit on Qantas, but you see that United cut their fares by 50% and you could get your money back and you can get there faster, what are you going to do? The loyalty that was once with a brand, even in healthcare, is breaking down. And it really is judged on the ability to satisfy the need of the patient and for the people who pay for the patient. So what have we gotten to? And here's where, I like to start looking at the acronyms. The challenge is, how can we as individual physicians, with the Academy membership being at one time about 60% private or small group, now about 25%, staying up with this and electronic healthcare needs is making it really nearly impossible to remain as solo or private, for the good, for the bad, for the indifferent. So we're seeing the entire demographic of neurology changing. Well, here is sort of a modeling, and I'm not looking at this for you to say, oh, how can we break down physician quality reporting system and value-based modifier again? Right over that little junction, you could learn all about these in much better detail and accuracy than I can give you. But what I want to point out is really this bottom line. They all start adding together. And meaningful use, you got a little bit of benefit if you signed up and accomplished it. If before 2015, if you were using PQRS, you might get a 0.5% more, a percentage more on your CMS reimbursements. Well, not now. This was set up to have a positive phase, the carrot, and now the negative phase, the stick. We're in the negative phase after about 7 years of initiation. So look what happens if you really can't meet these. A minus 3.5% last year, minus 6% this coming year. A margin, even in the Mayos and the Marshfields and the Texas institutions, the great big established ones, can't, with endowments that are enormous, can't sustain a 3.5% operating loss. 10%, I would challenge that any healthcare organization in the country, if their management team showed a 10% loss over 2 years, that the government's body would get rid of their entire leadership. You can't sustain it. It will put a Mayo Clinic out of business. So that is what is not investigational in this point or being looked at. That is reality. These are in the rules. So what's happening? This past year, a very good thing happened. The sustainable growth rate, which was that 20 to 25% reduction in fees that we would be paid for seeing patients, that threatened every 6 months, was thrown out. But what came in its place was a framework called MACRA, the Medicare Access and Chip Reauthorization Act. And that is heavily loaded with quality and value-based initiatives, which really are the direction that CMS and the government has taken. It combines CMS quality reporting with what's called a MIPS, Merit-Based Incentive Payment Program, or an alternative payment program. So there's MACRA, and there are MIPS, and there's APM. God help us. So again, over that area. And there are several talks this week, right here or in this area, about MACRA and MIPS. But what it is it's the new payment system. If you go to the AAN website and go under MACRA or practice, medical economics, they have an excellent report on this that's easily digestible, and they model 2 different conditions that we see heavily. So they've actually done modeling of what the visits would be for headache and for epilepsy. So go to our website, and there's a real, have you seen that, Eileen? It's not simple, but it is much easier to gain that than from other sources. So what is this too? The timeline is there, and it's very aggressive. You know, in the beginning, there's a slight upward adjustment to fees in the roll-in period. Now, that's a shorter roll-in than the other quality initiatives were, some of which were over 5 to 7 years. So when we look at MIPS, it involves quality, resource use, which is cost containment, clinical practice improvement activities, and meaningful use of medical record. So all of those triple aim areas are still back cooked into this. So that what you'll see is by the 2020s, you'll see potentially a 9% improvement in physicians or organizations. And I again say organizations, because on a personal basis, it's going to be very hard to do this with the resources available. You're going to see improvements. But what do we know about government budgeting? It's usually zero-based budgeting. For the people who gain, there is that advantage, but there is an equally structured offset for people who can't attain these fairly high areas. So really, in conclusion, I think of really the landscape of practice as 4 areas. You know, patient engagement and improvement. I look at the use of electronic health records, patient preference, payer preference, and then finally, our quality and volume to value. So those are the areas that are critical in trying to get a grasp of where the new reality is in healthcare. Thank you. These are brief. I know it's a lot of information, but if you go around to the midsection, all of these areas are covered in some of the booths and on the AAN website in individual pieces that you could absorb. Thanks.